Thank you, Angie, for that great intro and giving an overview of my talk. So that saves me a little time. Welcome, everybody. We are going to talk about hormone metabolism and how you can harness your knowledge after this talk to help patient symptoms. So first, I'm just going to go over some common questions. Because you might be wondering these, maybe that's why you came here. How does urine hormone testing compare to saliva testing or to serum? Urine testing is the only method that allows you to monitor the metabolism, detoxification, and elimination of both endogenous and supplemented hormones. And it allows you to assess the activity of all the enzymes involved. Urine testing looks at the endpoint of hormone metabolism, and it's not necessarily reflective of active tissue levels. That's where saliva comes in. Saliva represents the biologically active levels of hormones in the tissues. And also note that it's not clear how levels of urine hormones and metabolites relate to biologically active levels in breast tissue. And these terms might come up throughout the talk. Unconjugated hormones are sex hormones like progesterone, testosterone, estradiol. We also call them parent hormones. Conjugated metabolites have a side arm that allows them to be water soluble so that they can transport in body fluids, and this facilitates their elimination in urine or stool. So that's the difference. If I say parent hormones, I just mean the plain old hormone without a side arm on it. All of the analytes on the HuMap are tested via LC-MS-MS. This is the most sensitive and specific method available. It stands for liquid chromatography tandem mass spectrometry. There's more info on that on this slide if you want to know more. It's really accurate for samples that contain similar substances that could possibly interfere with other laboratory methods. So that's why we use that. And so a lot of providers want to know if you can monitor BHRT or HRT in the urine. You can, but the information you are getting is how those hormones are being metabolized, detoxified, and eliminated. As to judging if the dose you put your patient on is a healthy dose, urine might not give you information that specific. Saliva is my go-to for judging the dosage of supplemented hormones. And now I'll kind of go through different delivery methods of hormones and what happens to them in the urine so that you know, because you are going to be testing patients who are on supplementation. So you kind of want to know what that's going to look like in the urine. Oral hormones end up overestimated in the urine because conjugated metabolites are created in two places. So first, when the hormones are metabolized in the gut, and then a second time when they're metabolized in the liver. That way you end up with a lot more urine metabolites in the urine compared to tissue levels. And you're supposed to avoid oral hormones for 72 hours prior to and during the day of urine collection for this test. Topical hormones tend to be underestimated because urine testing isn't reflecting the tissue uptake of the topical hormones, and saliva testing is really the best method for topical hormones. This type of hormone delivery can be used the same day as urine collection. Vaginal hormones, it's not recommended to try to judge them based on urine. They can directly contaminate the sample. But if your patient is on these, it's fine. Just avoid them for 72 hours prior to and during the day of collection. Sublingual hormones are not subject to first pass metabolism, but it's inevitable that some of it gets swallowed. So then it goes through the same process that oral hormones would, leading to higher levels of metabolites possibly. So you avoid these for 72 hours prior. Injectables and pellets can definitely be looked at in the urine, they are passed through portal circulation, and you see steady increases in hormone levels with these methods. But again, these are excreted hormones and not tissue levels. If you are testing someone on injectable hormones, collect the urine halfway between doses. So if they're injecting something once a week, collect on day 3 or day 4 after that injection. And then can you use urine metabolites to guide your prescribing? That's not usually how I use urine testing. Urine testing can be done as an initial test prior to initiating bioidenticals, but then you tend to need to follow up in saliva if you want to know if your doses are within a certain range. And if you do want to get a before and after, you might start with saliva to begin with before you prescribe hormones. But urine is the only way you can see how hormone supplementation is influencing levels of metabolites that can impact health. And the really important ones to know are the 2-hydroxy, 4-hydroxy, and 16-hydroxy estrogens. It could be a really good idea to test patients on estrogen supplementation to see how it's being metabolized. It's good to test about 3 months after beginning supplementation to see how it's influencing this balance. And here's a summary chart. So everything I just said is in this chart. Just notice that if you're used to testing in saliva, the dosage intervals, meaning how long you have to wait after you use the hormone, they're kind of opposite in urine. So make sure you pay attention to the instructions and go through this particular chart with your patients who are on hormones before they do the test. If someone is a postmenopausal female on hormone supplementation, a white triangle plots the patient's values relative to the premenopausal reference ranges to give you kind of a guesstimate as to whether their current level of hormone on supplementation is within a range that a body could feasibly make. So that's what this is showing you, the white triangle. So now, when do you consider urinary hormone metabolite testing? You can learn a lot about a patient's health by seeing how the major steroid hormones are being metabolized. Like a fingerprint, metabolism is unique to each individual. And I've listed quite a few conditions and symptoms that might lead me to want to run urine hormone testing. I think it's especially helpful for patients with PCOS because often you get quite a few actionable findings on the HuMap. Also, males with sexual dysfunction, lower urinary tract dysfunction, hypogonadism, and so on. I really like to see how much of the testosterone is being aromatized into estrogens and also how much is being converted to DHT. And I like to look at estrogen detoxification for patients with a family history of breast cancer or prostate cancer. And like I said before, the test is appropriate for males and females, but there aren't any reference ranges for prepubescence. So it's not recommended to test males under age 12 or females who have not yet started menstruating. If you want to test their hormones, saliva would be more appropriate for these younger patients. Collecting for the HuMap involves 4 urine samples in a 24-hour period, a 5th sample if the patient wakes to void in the middle of the night. And this is a simplified way to account for pulsatile hormone secretion without having to collect all urine in a giant jug for 24 hours. For cycling females, it's important to determine the best day to collect based on the length of their cycle. I get a lot of calls about this, when to collect. My patients' cycles are irregular. Typically, you test on day 21, give or take 2 days if your patient has roughly a 28-day cycle. But if someone has a shorter, longer, or missing cycle, you can use this chart. This is also in the instructions. There is a link you can access to get this information. The first page of the HuMap is very colorful and I think it's very attractive and beautiful. It summarizes your patient's results with color-coded visuals so that once you get used to the lay of the land here, you can just glance at this page and the clinically actionable findings are going to jump out at you. And once I give you a tour, this should feel much less overwhelming. Right now, it's just looking like a lot of colors, but I will walk you through this and then you will feel confident in interpreting this test, especially from the first 2 pages, which gives you everything we tested in kind of an abbreviated format. Here's the key for the color coding. There it is. Light blue and yellow are the bottom and top 10% of the reference interval. The rainbow arc here will show you your patient's levels of estradiol, estrone, estriol, which I like to say E1, 2, and 3 for short, 4-hydroxyestrone, 2-hydroxyestrone, the ratio between these two, progesterone, separately alpha and beta pregnenolone, allopregnanolone, and then the sum of DHEA plus DHEA sulfate, testosterone, and 5-alpha DHT. You also get total cortisol throughout the day, cortisone per day, and then metabolized cortisol, which is the sum of alpha and beta THF and THE. Lastly, you get 8-hydroxy-2-deoxyguanosine. And the little letters on the left of each analyte indicate what hormone neighborhood it belongs to, whether it's an estrogen, a corticoid, an androgen, progesterone, or an oxidation marker, which there's just one. It's that 8-hydroxy-2-deoxyguanosine. These same 15 analytes will move around and change colors based on a patient's individual levels. In the estrogen section from the summary page, we highlight the 2-hydroxy, 4-hydroxy, and 16-hydroxy metabolites, and then show you how well they're being methylated. So I'm going to focus on the methylation activity in this example. The red rectangles on the bottom represent that there's a higher amount of methylated estrogens compared to hydroxyestrogens. And that's not necessarily an issue with excess COMT activity. It could be, but often I find this pattern in patients with constipation because the methylated estrogens are not being eliminated from the body efficiently. And this is a big reason why nutrition and a well-functioning digestive system are really important for hormone balance. Here's another example. You have 4-hydroxyestrogens, these red circles next to where it says phase 1, they're high, and I don't like that they're not being methylated efficiently. If you look at the gray bars on the right, you can see that the percentage of 4-hydroxy is high, and this increases the potential for DNA damage. The 16-hydroxyestrone percentage also is high, and this metabolite is highly estrogenic. So for further clarification, between these dotted lines is the reference interval for each of these percentages, and then the darkest gray zone in the middle is the optimal range. So hopefully you can see that now. Third example, the 2-hydroxy percentage is high and the others are low. And this tends to equate to lower risk of hormone-driven cancers and also estrogen-dominant symptoms. However, the fact that the hydroxylated estrogens are not being methylated efficiently, if you see those dark blue rectangles on the bottom, that's a concern and treatable. So now we're in the corticoid section. Cortisol and cortisone are plotted together on this graph here to illustrate the relationship to one another. The solid line is cortisol, and then this dotted line is cortisone. This patient is favoring cortisol, if you look at this dial, and that's the less preferred, less usual finding because it can be associated with insulin resistance, PCOS, obesity, metabolic syndrome, inflammation, and thyroid conditions. That can lead to more cortisol compared to cortisone showing up in the urine. It's more usual to have twice as much cortisone as cortisol in the urine. And one thing urine testing provides that other mediums can't show you is that it allows us to extrapolate information about enzyme activity by looking at the analytes before and after the enzyme. So 3 areas are highlighted on the summary page, and I'm going to read this little blurb for you. Metabolites in the 5-alpha pathway are more androgenic than their 5-beta counterparts. So I'm talking about especially 5-alpha DHT. And this can cause more androgenic symptoms even when hormone levels appear normal. Next, you have aromatase. Aromatase is an enzyme found in the greatest amounts in peripheral fat tissue, and it can increase estrogens in both males and females. And then down here, we're looking at how well 4-hydroxyestrone methylates to form methoxyestrone. So we're looking at COMT activity just there. This particular metabolite is unfavorable because of its carcinogenic potential within the breast and prostate tissue, and it's a reactive metabolite. When COMT methylates it, it becomes more stable and it can be removed from the body. So notice here, there's a really high ratio of 4-hydroxy to 4-methoxy estrone. And it's a good thing to make sure that the hydroxy estrogens are methylated. But when the ratio is high and the methoxy estrogens are elevated more so than the hydroxys, it could be due to a lack of phase 3 detox, which is elimination from the body. So you want to make sure people are getting enough fiber and water and eliminating regularly. Page 2 of the report shows you the entire steroid hormone cascade color-coded based on your patient's results. So this is every analyte we tested, plotted as to how the body converts and metabolizes them. So what direction all that goes in. At a glance, you can kind of see which hormone neighborhoods are hotter or colder. And so now I'm just going to emphasize each neighborhood. Progesterone's upper left, corticoids upper right, androgens bottom left, so that's like testosterone, DHEA, and then estrogens are on the bottom right. To demonstrate the dynamic nature of the HuMap, these are real reports from different patients. So let's just make a quick assessment of these from this bird's eye view. Patient 1, everything's mostly green, optimal values. So that's really good. Patient number 2 on the top right, this is mostly dark blue values. They're low. Patient number 3, on the bottom right of this one, we have elevated estrogen metabolites. So really quickly, you can kind of zero in on which areas you might need to focus on. Don't get fixated on correcting every single analyte that's not green or optimal. Just take a step back and look at the report as a whole. We can think of the dynamic steroid hormone cascade like a river. Is it flowing? If you compare the levels of the analytes before and after an enzyme, this shows you the enzyme's activity. So is it slow like there's a dam in the way, or is there faster movement like there's a waterfall? And then also, is it resulting in excess or deficient hormone levels? And then do these correlate with the patient's clinical presentation? So that's kind of the thing that matters the most. Does it matter to treat this thing that you found? And we need to retrain our clinical brain to see these colors in a different way. Blue, which means it's low, we say it indicates lack of abundance or less movement down that metabolic pathway. And then red can indicate the opposite. Sometimes it's preferable to have higher or lower levels of certain metabolites or to have certain ratios skewed more in one direction. And as we go through each of the hormone neighborhoods, you'll understand this better, which is what we're going to do now. Starting with the progesterone neighborhood. Most urine metabolite tests don't offer actual progesterone levels, but our lab has the ability to measure progesterone directly, and an estimation is not needed. Most labs add the alpha and beta pregnadiol together to estimate that, but we give you the progesterone here. When an analyte is overtly high or low, commentary is going to show up at the end of the report to let you know the possible clinical correlations with that finding. Just keep in mind, it doesn't automatically mean your patient has one of these conditions. Just imagine that at the end of each of those blurbs, it says, or none of the above. So, for example, PCOS patients may have increased 17-hydroxyprogesterone and elevated 5-pregnine trial. And then patients with insulin resistance could have increases in 17 and 21-hydroxyprogesterone. Also, you could see an elevation in one of those, and it could be none of these things. Here are 2 examples I found of females on oral progesterone supplementation, because oral progesterone can increase allopregnanolone, this particular metabolite, and it also can increase all of the progesterone metabolites. Allopregnanolone crosses the blood-brain barrier and stimulates the GABA receptor, so that's why oral progesterone is really helpful for sleep and anxiety. If you're testing your patient on oral progesterone, don't expect it to look exactly like these 2 examples, which are identical to one another. This is just what I pulled, and by coincidence, they look exactly the same. One other thing that can increase progesterone and its metabolites is oral pregnenolone supplementation. Transdermal supplementation tends to be underestimated because the hormones go to the tissues before being metabolized. So here I'm contrasting that oral progesterone report on the top with the transdermal progesterone report on the bottom. And just notice, in general, you're getting more low values on this one, although it's kind of a rainbow for this particular patient. Is there any utility in testing a patient on oral contraceptives? Well, hormonal contraception, especially if it's a combined pill, meaning estrogen and a progestin, suppresses ovulation and then will definitely lead to progesterone insufficiency, often low estradiol, and sometimes suboptimal testosterone. Urinary testing can elucidate how the hormones are being metabolized, detoxified, and eliminated, and that will allow you to find ways you can help the patient balance and process and metabolize their hormones alongside the birth control if that's something that's needed. But anyway, here are two examples. This one on top is on a combined oral contraceptive. And look, all the progesterone metabolites low or lowish. All the estrogens here are overtly low. That's because she's not ovulating. This next one is someone on a progestin IUD. It doesn't always suppress ovulation. It has other mechanisms of preventing pregnancy. So this patient just has suboptimal levels of progesterone metabolites. So this patient might still be ovulating, especially since all the estrogens are optimal. So depending on which birth control your patient is using, you can get different results. Also, oral progestins don't always suppress ovulation. So that might be another case where testing, you can kind of find out, is it probably happening or not? Now we're in the corticoids neighborhood here. Cortisol versus cortisone is shown here. Metabolized cortisol is all of these, and then you get separately the cortisol graph and then the cortisone graph. And then on the bottom, you get these ratios / calculations, all the metabolized cortisol added together, and then you're dividing the cortisol by the cortisone metabolites on the bottom here. So cortisol is the active form of the hormone, and then cortisone is the storage form. The 11-beta HSD enzyme is most active in the kidney, and there are two versions of it. The one version pulls cortisol out of storage, activating it. And this can be affected by obesity, metabolic syndrome, inflammation, and thyroid function. 11-beta HSD2 is protecting the mineralocorticoid receptor from cortisol's effects. So that's converting cortisol back into its storage form. And because we're looking at the influence of the necessarily seeing the HPA axis activity directly, but rather the body's response to the cortisol levels. And we're filtering it through this lens of what is going on metabolically, whether there's metabolic syndrome, thyroid function, and so on. Metabolized cortisol adds THE, 5-alpha THF, 5-beta THF. We are measuring what the body has utilized. If it's high, it's indicating increased cortisol clearance due to overproduction of cortisol, which can also be influenced by obesity, insulin resistance, hyperthyroidism. If it's low, this is decreased cortisol clearance, which could be due to obesity, inflammation, insulin resistance, or hypothyroidism. And then when we're dividing the metabolites, this ratio, because free levels of cortisol can be converted in the kidney before excretion, looking at this ratio gives clinicians a better idea of overall preference within the body. Sorry, I just read that slide, but it's important. Okay, these are some patterns I found on corticoid reports that you might see in your patients. Underweight patients may have decreased cortisol metabolites. So I had a report from someone whose BMI was under 18 and the metabolized cortisol was suboptimal. On the bottom left, hypothyroidism can slow cortisol clearance and decrease the cortisol metabolites. So almost everything was low there. On the top right, obesity can increase the cortisol clearance and 11-beta HSD1 activity, causing a cortisol preference. And then hyperthyroidism can upregulate liver clearance of cortisol. So these are real examples. I snipped them from real reports to share with you. So cortisone is protecting the tissues from the effects of cortisol. Therefore, if 11-beta HSD activity is functioning properly, you should have twice as much cortisone as cortisol, and that's measured in the cortisone to cortisol ratio. And then the metabolized cortisol is showing you what the body has utilized, and the ratio of metabolites is indicating metabolic preference. If the patient is suffering from too much cortisol, here are some supplementation ideas that can slow the activation from the storage form, including polybasal, progesterone. EGCG is, it comes from green tea. It's epigallocatechin something. So that's what that word means. Rooibos tea, also very tasty and can be really helpful in lowering cortisol levels. Here's the androgen neighborhood. Adding the active DHEA to the sulfated storage form gives you a more comprehensive look at the status of this hormone, because it can be, the stored form can be activated into DHEA. So I think it's helpful to look at both of those. So these are the ratios you get in the androgen neighborhood. This is from a report from a 67-year-old postmenopausal female on progesterone, and she has really low 5-alpha reductase activity. That's often a treatment goal to try to reduce androgenic symptoms in females, but in this case, she's supplementing progesterone, and progesterone downregulates 5-alpha reductase. Also, her testosterone to epi-testosterone ratio is high, and she's not on supplementation, but her husband is using androgel, so we know where that excess testosterone came from in her case. And then I'm just going to read these bullets on the bottom. Looking at the androgen neighborhood can help you evaluate conditions like PCOS and hyperandrogenism in females, hypogonadism in males, metabolism of supplemented testosterone, obviously. And then, like I said, that testosterone to epi-testosterone ratio may reveal undisclosed supplementation or exposure. Aromatase is also called CYP19A1. It converts androstenedione to estrone and then also testosterone to estradiol. So I circled where it is on this hormone cascade. It's active in the adipose tissue, and it can be involved in carcinogenic activation of environmental toxins. Oh no. So here is another example report. This is a complicated case, but I just wanted to show you a few things about it. It's a 57-year-old male with metabolic syndrome, trouble losing weight, and he's on transdermal testosterone. The main actionable finding I want to highlight here is the excess aromatase activity. If you look down here, too much conversion. So for a case like this, you might think about natural aromatase inhibiting herbs and supplements like chrysin, progesterone supplementation, and then also addressing factors that contribute to excess aromatase, metabolic syndrome specifically. So treating the metabolic syndrome should be helped with hormone metabolism and balance. Andropause and menopause often come with weight gain around the waist, and testosterone levels convert to estrogen. Then more adipose tissue can develop around the abdomen, which increases the activity of the aromatase. This causes inflammation, and then it's also exacerbated by poor food choices. Too much aromatase activity increases estrogen levels, which can negatively impact erectile function, libido, and sperm production in males. And aromatase can convert testosterone to estrogen locally in the breast tissue. This activates estrogen receptors that upregulate BCL2, which is an anti-apoptotic protein, meaning it prevents cell death. Deregulated expression of these proteins has been found in a number of types of cancer, including breast. And all of this is consistent with the fact that there's an increase in breast cancer that has been observed in postmenopausal females who had higher serum testosterone levels, because this resulted in higher estradiol locally in the breast tissue. How can aromatase be downregulated? So I've highlighted some common ways to do this, but you also want to think about improving stress coping, avoiding xenoestrogens, lower glycemic index diet if needed, reducing adipose tissue as you can, reducing alcohol, and then zinc, chrysin, damiana, grapeseed extract, and nettles. There are pharmaceutical aromatase inhibitors, but these can cause side effects in men like erectile dysfunction and hot flashes. So unless there is a medical necessity for these medications, if you're just trying to decrease aromatase activity for purposes of hormone balance, you might consider these other natural options to increase the testosterone. So here's 5-alpha reductase. It converts testosterone to its more potent form, DHT, which has 2 to 3 times the affinity for the androgen receptor than testosterone, and it can lead to an increase in androgenic symptoms in females like acne, scalp hair loss, mood instability. And then in males, you can get some of the same symptoms, but then also prostate concerns. Saw palmetto, nettles, progesterone, and zinc all downregulate 5-alpha reductase. And so remember, when you're looking at your follow-up results, you also have inhibited metabolites in other neighborhoods. So that will help explain why. We compare the metabolic preference of 5-alpha reductase versus 5-beta reductase. The alpha metabolites are more potent, especially the 5-alpha DHT. And that can produce symptoms like facial hair growth in females. DHEA is a prohormone that can convert to androgens, and then those can aromatize into estrogens, DHEA being the active form, and then DHEA sulfate is inactive. When you add these together, you get a better idea of the total pool of DHEA, and you see these both on the rainbow arc on the front page of the report, and then also in the androgen section. And this is how the androgens looked for one patient with PCOS. Just notice the elevated testosterone, upper range DHEA, along with other elevations in the neighborhood, especially those that result from 5-alpha reductase metabolism. Transdermal supplementation tends to be underestimated in urine because the hormones go to the tissues before being metabolized. This is from a male who is on a high dose of topical testosterone. I believe he was on 100 milligrams or more per day. And even with the underestimation of metabolites and conjugated hormones, he has quite an abundance of androgens on this report. The dosage interval was 72 hours. And we recommend using topical hormones the same day as testing. So he waited a long time before testing and the metabolites were still high. So this is potentially telling us something about the dosage. These are the analytes and ratios you look at in the androgens section, and you'll be viewing these results through the lens of the patient's symptom picture, especially things like hirsutism in females, erectile and lower urinary tract dysfunction in males, trouble losing weight, and more. Now we're talking about estrogens. These come from the androgens that get aromatized. And then the estrogens go through phase 1 metabolism to become hydroxyestrogens, or also called catechols. And then in phase 2, they're methylated by the COMT enzyme, which marks them for excretion. And the balance between the different catechols and whether they get methylated efficiently can greatly impact symptoms and then also risk of hormone-driven cancers. Our HuMap report shows you aromatase activity in 2 places. Other smaller urine hormone panels on our menu will not give you this enzyme calculation. And this is a real example of the androgens and estrogens from a 43-year-old female who's premenopausal, has a BMI of 27, and her symptoms are hirsutism, irregular cycles, scalp hair thinning, and central adiposity. I think you can see what's going on here. The androgens are just not aromatizing to the estrogens. The solution here in women is usually not to increase aromatase, because most things that do this are simply poor health choices, with the exception of the herb Coleus forscoli. So that might be a consideration depending on what other things we're trying to do. Treatment for a case like this would most likely be aimed to balance the blood sugar, decrease the androgen production, and encourage ovulation. So phytoestrogenic herbs and phytoprogesterones might be considered. Actual topical progesterone supplementation also might be a consideration. The ultimate biologic effect of the estrogen depends on how it's metabolized. And this is taking place in the liver through phase 1, hydroxylation, and then phase 2, methylation and glucuronidation pathways. And it makes fat-soluble estrogens into water-soluble compounds and then marks them for excretion. Phase 1 also transforms antibiotics, pharmaceuticals, and xenobiotics. If the intermediary phase 1 metabolites are not excreted from the body efficiently, this can lead to tissue damage and DNA damage. So, zeroing in on phase 1, the catechol estrogens, 2-hydroxyestrone is thought to be the safer or less estrogenic pathway, and then 16-hydroxyestrone and 4-hydroxy are thought to be less safe, more estrogenic, and have the potential to cause DNA damage and increase the risk of breast and possibly prostate cancer. Often we want to increase the activity of the CYP1A1 enzyme to ferry estrogen down the safer 2-hydroxy pathway. Although other toxins are moving through the system and turning into even more dangerous intermediates, things like polycyclic aromatic hydrocarbons, which are cancer promoting. And this enzyme also activates the aflatoxin B1, which I think comes from contaminated peanuts, and also tobacco intermediates. These are both carcinogenic, and that's why you need to ensure that all phases of metabolism and detox are happening, phase 2 and phase 3 again. Here are some ways to upregulate, which include cruciferous vegetables, DIM, which comes from broccoli, resveratrol, fish oil, and tea. Here are some snippets from a report for a 32-year-old premenopausal female who'd been on DIM for 3 months. I highlighted this one because you can see that her 4-hydroxy to 2-hydroxy ratio is optimal. So it does seem like the goal of taking DIM is working. And then you also see in the gray bars here, the 2-hydroxyestrone percentage is in the optimal range. And then the 4-hydroxyestrone percentage is in range, but lower. So that's why the DIM is helping. The 16-hydroxy is perhaps upper range, but I think that's less crucial than making sure that the 4-hydroxy is lower than the 2-hydroxy. So this is a really good report. These are some downregulators of CYP1A1, grapefruit juice, berries. Green tea can actually upregulate or downregulate 1A1. Lycopene, which tomatoes are known for having this, is an option too. And then there's this 10-herb formula, which I think I can tell you is Zyflamend. Don't avoid these foods just because you want to upregulate the 1A1 enzyme. Just make sure you are amping up the 1A1 promoters. You want to have the option both to upregulate and downregulate. And the body has innate intelligence to balance itself out greater than any medication. So it really is okay to eat a wide variety of fruits, vegetables, herbs to just make sure your body has the tools it needs to do what it needs to do. CYP1B1 takes estrogen down the 4-hydroxy pathway. Usually this is less desirable from an estrogen perspective, but there are some positives to this. This enzyme is more prevalent in tumor tissues. It increases fat uptake, and it's associated with metabolic syndrome, but it also has these beneficial functions. It seems to protect from cancer in some cases too. Mice that do not have enough CYP1B1 have more lung tumors. It helps in eye development, reduces oxidative stress. And we often try to oversimplify these concepts so they're easier to learn, but with hormone metabolism, balance is the key. We don't want to completely be missing the actions of an enzyme. It's necessary to have all of the enzymes. Expression of 1B1 has been shown to be increased in prostate cancer. I just made this slide because we talk about breast cancer and preventing it a lot when we talk about hormone balance and metabolism, but I just wanted to show you this is also relevant for men. It's also relevant for the prostate. There is some research on this, and anyway, that's why I'm sharing it. Higher expression of 1B1 has been correlated with higher Gleason scores, worse survival rates, and resistance to androgen deprivation therapy. And the enzyme can be upregulated by environmental toxins, UV exposure, cannabis, biotin, and insulin resistance. So it's a good idea to avoid biotin supplementation prior to testing. Downregulation is usually the goal with this enzyme, allowing more estrogen to go down the 2-hydroxy pathway. Beneficial foods would include carrots, celery, grapefruit, tomatoes, rooibos tea, resveratrol, and quercetin. So I do believe tomatoes were mentioned for upregulating 1A1, and then they downregulate 1B1. CYP3A4, I think, doesn't get as much attention, but it moves estradiol to estriol, and then it moves estrone to 16-hydroxyestrone. It also deactivates testosterone to biologically less active metabolites. And then caffeine, testosterone, progesterone, and androstenedione are substrates of the 3A4 enzyme system, and so are various pro-carcinogens, including aflatoxin B1, polycyclic aromatic hydrocarbons also. And I included a little picture of how this one is affecting testosterone and estradiol, because just so you can see. Anyway, if you want to upregulate it, St. John's wort, capsaicin, valerian, and ginkgo, and then optimizing vitamin D are important. Females, tobacco smokers, and diabetics tend to have higher 3A4 activity. Downregulating this enzyme can happen if you eat kales, beans, spinach, broccoli, Brussels sprouts, soy, and horseradish, or wasabi. In the next step of metabolism, now we're in phase 2. These enzymes are breaking down the toxins into water-soluble compounds and then reducing the toxicity of the phase 1 products. And this is completed by adding various groups like a sulfur, glutathione, glucuronic acid, amino acids, and then methyl or acetyl groups. Modulating the phase 2 enzymes by a food-based bioactive compounds could be advantageous in patients who have altered enzyme activity due to genetic polymorphisms, or if they have a high toxic burden due to chronic exposure to pollutants in the environment, or an overactive phase 1 activity, and then also just in general hormone imbalance. So here's phase 1 and phase 2 now. The phase 1, 2-hydroxy and 4-hydroxy estrogens can potentially be converted to quinones and semiquinones, which are highly reactive molecules. They can form reactive oxygen species and damage the DNA. But if all goes as planned, then these metabolites are detoxified via methylation, rendering the harmful 4-hydroxy metabolite significantly less active, and it also activates the protective 2-hydroxy estrogens into the beneficial and more active 2-methoxyestrones. Glucuronidation and glutathione conjugation are two other key phase 2 liver detoxification pathways that mark the estrogens for elimination, and you'll see it in a little bit. And these pathways are active in breast tissue for protection against damage caused by reactive metabolites of endogenous and exogenous chemicals. I'm highlighting here where phase 2 is happening on the hormone cascade. The important point is that phase 2 inactivates the catechol and marks them for excretion. Looking at methylation potential allows you to assess risk. The higher the ratio of methylation, the less potential for reactive quinone formation. And even if the 4-hydroxy metabolites are elevated, adequate methylation means that the metabolites are being detoxified, rendering them less harmful. So this is shown on 2 places. You got this summary on page 1 where you see the methylation activity, and then all 4 of those ratios are shown in the estrogen section of the report. This diagram is pointing out that there are 3 main ways to decrease the potential that 4-hydroxyestrogens form DNA adducts. So if you look at the blue markers, you can downregulate CYP1B1, you can support methylation and the COMT enzyme, or you can support the glutathione sulfotransferases to mark the quinones for elimination. So actually that's 4, 1, 2, 3, 4. They're kind of 4 strategies that you can use. So with that in mind, B12, methylfolate, and P5P, which is B6, support MTHFR. SAMe is the methyl donor for COMT, and then magnesium is a cofactor. DIM upregulates CYP1A1, pushing the 2-hydroxy pathway, which forms more stable metabolites. And then the foods and herbs at the bottom support those enzymes that mark the quinones for elimination, the glutathione sulfotransferases. Don't forget to address factors that could be slowing the COMT function. This highlights why lifestyle can be foundational when treating hormone-related complaints. We need to ensure that there's adequate sleep, keep the blood sugar balanced, address stress in the HPA axis, and then also bring down oxidative stress. Some HRT formulations contain conjugated equine estrogens, or CEE, and these can form harmful metabolites that can inhibit our detox enzymes, including COMT and the glutathione sulfotransferases. And this can increase breast cancer risk, especially for those who are homozygous for the polymorphic COMT variant. Unmethylated 2-hydroxy and 4-hydroxy metabolites, as I said before, can become oxidated into quinones or semiquinones, resulting in DNA adduct formation and then DNA damage. And on the HuMap report, you can look at the ratios of 4-methoxyestrone and estradiol to 4-hydroxyestrone and estradiol, and then 2-methoxyestrone to estradiol to 2-hydroxyestrone to estradiol, that was a mouthful, to determine if adequate methylation of catechol estrogens is occurring. N-acetylcysteine and resveratrol have been shown to inhibit quinone and semiquinone formation. And this is showing you all of the effects of this combination on estrogen metabolism. Resveratrol is purple, and then N-acetylcysteine is blue. So basically, you don't want to go all the way to the right here. These are the depurinating adducts. So you want to try to allow glutathione sulfotransferase a chance to eliminate things. And then you also want to allow COMT to eliminate things. And that's just what this combination does. It basically blocks the formation of the DNA adducts and helps ferry the metabolites this way to allow these enzymes a second chance to eliminate the harmful metabolites. Elimination is also called phase 3 when the breakdown products leave the body through urine or stool. And this diagram is showing you the nutrients you need to support phase 1 and 2 detoxification. And foods that are especially supportive here include cruciferous vegetables, berries, soy, garlic, and then spices like turmeric. Keys to healthy elimination, you probably already know, since you're probably already familiar with functional medicine techniques. But anyway, adequate hydration, maintaining bowel regularity, and then also supporting the microbiome abundance and diversity through adequate fiber and a wide variety of plant foods in the diet. The estrobolome is a microbiome made of colonic bacteria that induce estrogen metabolism via the enzyme beta-glucuronidase, which can deconjugate estrogens and allow their reabsorption. A healthy microbiome with adequate abundance and diversity ensures proper phase 3 activity, allowing fecal excretion of conjugated estrogens. On the other hand, a standard American diet and lots of toxin exposure is associated with excessive deconjugation, leading to recirculation of too many estrogens. As I pointed out before, clues that you need to support phase 3 would be if the methylated estrogen to hydroxylated estrogen ratios are high, if there's constipation or significant digestive symptoms, if the diet is generally really unhealthy, or if you have elevated estrogens and androgens without a simpler explanation. And considerations here include soluble fiber, which is in things like oats and Jerusalem artichokes. Make sure to include 30 different plant foods per week to promote microbiome diversity. And then calcium D-glucarate can help bind and eliminate excess estrogens. Also, be sure to moderate or eliminate alcohol, improve coping with stress, and then also reduce or eliminate sugar. So the estrogen section shows you the levels of the cleared parent hormones E1, 2, and 3. It's another place to evaluate aromatase activity, and then also phase 1, 2, and 3 detoxification. 8-hydroxy-2-deoxyguanosine is a marker of oxidative damage, which is tested alongside estrogen metabolites because it can be helpful in identifying or confirming damage from quinones and DNA adducts. Many common conditions are also associated with oxidative stress, and that includes psychosocial stress, inflammation, insomnia, specifically in postmenopausal women, hypertension, depression, and irritable bowel disease. So when that marker is high, it could be because of problems with estrogen metabolism, but also consider if any of these are going on in the case, because the treatment for elevated OHDG is address the cause, or think of these supportive nutrients and foods. Green tea comes up a lot for balancing everything on the HuMap. And acetylcysteine is really helpful for a lot of reasons. Yoga also has been shown to decrease oxidative stress, and fish oil. So now that you know all about hormone metabolism and how to interpret and treat imbalances found in the urine testing, why might you prefer to use the HuMap? What stands out about Dr. Data's urine testing? The main advantage of liquid urine collection is enhanced sensitivity, especially for low concentration metabolites. Dried urine has to be reconstituted from filter paper once the sample arrives, and then the reconstitution can lead to loss of polar steroid metabolites or creatinine for some patient samples. Liquid samples can be shipped after being frozen for 4 to 6 hours. They can be processed faster compared to dried urine, and then also it can be concentrated further to enhance the detection of low-level analytes. Steroid hormones and metabolites are also quite stable in preserved liquid urine. And additionally, DDI's HuMap includes all of these metabolites and ratios that competing labs do not include. So everything on this list that we went through throughout the talk. Here are the main points that we've gone over today. This is what the HuMap can give you greater insight into. You can look at that 5-alpha versus 5-beta metabolism. You can look at phase 1, 2, and 3 detoxification. You can make a potential risk assessment, and you can look at the movement of hormones along a particular pathway, and it also is illustrated in full color for you. And this can assist you with complex cases where salivary testing might appear normal, but the patient still has symptoms. So lastly, I want to show you where you can find our newly released resource guide, and this serves as an index of everything that can promote or inhibit the enzymes involved in hormone metabolism. This chart is just a preview. I picked 10 herbs or supplements that have the most wide-reaching effects on the enzymes, and it can help you cut down on how many different things your patient has to take. And it also serves as a cross-reference so that you don't cause unintended effects with your treatments. So that's this chart. If you use this link here on the bottom, that will take you straight there. Here's how you can navigate there. If you don't have the link, you just go to doctorsdata.com/HuMap, and then look at the bottom right under Find Out More, and then select HuMap Clinical and Therapeutic Considerations. There also is this resource guide that includes the clinical and therapeutic considerations within it. So either here or here, that will get you there. It will be really helpful. It will help you figure out, what can I do about these enzyme issues? And all the references are all there. So now we've come to the end of the talk. Hopefully you're still with me, and let me know if you have any remaining questions.